All right, good morning, everyone. Again, this is the Angioedema, November 22nd, 2022 in service. It is not 2023. I know it's a whole year away, but it's only 2022. It's all good, Caitlin. I just caught it as well. But we're going to do the November 22, 2022 in service on angioedema. And I know a couple of you are probably going to have questions. If you can, either type them in chat or just wait till the very end. So I'm going to turn it over to Caitlin.
Okay, yes, as Dr. Waldman said, my name is Caitlin, and today we are going to talk about angioedema. So our learning objectives for today, I'm going to describe the epidemiology of angioedema, define angioedema, explore the different classifications, recognize the different symptoms, recall the causes, and then review the treatment and prevention tactics for angioedema. So just a little bit of background information first. So back in 2016, the World Allergy Organization stated that 40 to 50% of patients that have chronic urticaria or hives also have concomitant angioedema. Some patients are at a genetic predisposition to angioedema, which we will talk about in a little bit. Normally, it appears in early adolescence and then has a peak incident in their 30s. There is the chance of females having a higher prevalence rate due to the higher levels of estrogen. There can be an increase in hospital admissions with those that are 65 years and older. And then as pharmacists, we know that African Americans do have a higher risk of angioedema when taking our angiotensin converting enzyme inhibitors or our ACE inhibitors, which we will also talk about in a little bit. So I just wanted to review some important definitions since angioedema is a combination of two words. So edema is ultimately the swelling due to excess interstitial fluid that's trapped within our tissues of our body. Angio means vessels. And so angioedema is non-pitting edema. And so non-pitting edema is actually like you're able to kind of press on the skin and it doesn't make like a hole, like a pit, that's localized to the subcutaneous and or submucosal tissue layers of the mouth, the larynx, the face, the neck, the GI tract. Anything that is like a mucosal tract, angioedema can affect. I did provide a picture at the bottom just to kind of show you the difference between hives or urticaria and angioedema. So hives generally just sit on the top of the skin. They have a little bit of fluid in them, but angioedema itself is like fluid underneath the skin. So it gives that swollen appearance that people can see. While I did mention most of the time it is submucosal tissue layers like the face that are affected, sometimes the extremities can be affected. And that's something that's important to kind of differentiate between like edema that may be caused by heart failure or some other kind. So the pathophysiology for angioedema is quite complex, so I'm going to simplify it as best that I can. There are two different pathways that they believe causes angioedema. So you have mast cell mediated or histamine mediated, as I will refer to it, and then kinin related, as I will refer to as bradykinin mediated. So we know that we can have allergens that attach to our like IgE, which is just immunoglobulins in our body, that can then attach to these mast cells, and then that can release histamine, which can lead to urticaria or itching or flushing and things of that nature, and then leukotrienes and prostaglandins that can lead to inflammation. Or the allergen can directly stimulate the mast cell and it releases those as well. Generally, people that have histamine-mediated angioedema, the angioedema occurs like relatively soon after exposure and only lasts like 1 to 2 days. For patients that have bradykinin related, it does last like 3 to 5 days in duration. And so with the mechanism of that, so it's actually part of our immune system also, but part of our coagulation cascade, so how our blood clots. And so we have this HMWK, this high molecular weight kinin that our immune system has in our coagulation cascade. So ultimately this cholecalciferin right here takes high molecular weight kinin and breaks it to bradykinin, and that's where the bradykinin mediated comes from. Our body has ACE that can then inactivate it and it doesn't cause any problems, but there can be issues with the breaking down of bradykinin or making too much. So ultimately bradykinin mediated is due to too much bradykinin in the body. They're either making too much or they're not getting rid of it fast enough. And this C1 inhibitor right here will become very important when we talk about hereditary causes of this. Ultimately, that is responsible for regulating the amount of bradykinin in the body. So if that's deficient, then our regulation is also deficient. So the different classifications, we have acquired and we have inherited. So for acquired, obviously this happens as your life goes on, and inherited, you're born with it. So allergic or histaminergic is one of the most common causes of acquired angioedema. We then have non-allergic or non-histaminergic. We have drug-induced, which can be histaminergic and non-histaminergic, kind of just dependent upon how the drug works in the body, can depict on how, like, which, if is it going to cause like urticaria or not. You can actually have an acquired C1 inhibitor deficiency, and then idiopathic or an unknown cause. For inherited, we have, again, the C1 inhibitor deficiency, but this is where you're born with it. So it's hereditary angioedema. And so there are 3 different types of this. So you have type 1, which means you lack that C1 inhibitor molecule, so you're not able to regulate how much bradykinin is in your body. Type 2, it's dysfunctional. So like sometimes it may work and sometimes it might not. And then type 3, it's interesting because it is a normal molecule, but we'll talk about a little bit later on why that occurs. So you can have this C1 inhibitor as an acquired angioedema and also an inherited one. So that's an important distinction. And some of the causes are very common for angioedema. So we know that drugs can cause them. As pharmacists, we know ACE inhibitors are a really big contributor to angioedema. And like I said, African Americans are at a higher risk, and they do believe that that is due to like a genetic polymorphism that they have. NSAIDs and aspirin can also cause it, along with morphine and codeine. Different foods can cause it as well. So just kind of think of the foods that patients may say that they're allergic to. So like eggs or fish, nuts, fruits, and even meats. So just kind of knowing the foods that most, like the common foods people are allergic to. External causes can also cause angioedema. And a lot of those stem from the hereditary angioedema and the acquired C1 inhibitor deficiency angioedema. And so that can be infection, surgery, pregnancy, stress, anything that causes a lot of like stress onto the body can cause an angioedema attack. Again, genetics, and then insect bites, so like wasps and bees. So anything that you kind of think that people could be allergic to also could be a cause of angioedema. So for presentation, we have a lot of different symptoms that patients may present with when they're having an angioedema attack. So a lot of the times it's broken into, is it histamine mediated or bradykinin mediated? So if they're presenting with urticaria or hives, flushing, so like a red tint to their skin, pruritus or itching, bronchospasm, so a difficulty in breathing, normally that's a histamine mediated cause. So it could be due to an allergen or something of that nature. If it's bradykinin mediated, you don't necessarily have those symptoms, but you have more abdominal pain or abdominal distension and vomiting. And you can have acute angioedema and chronic angioedema, just kind of depending on the classification that you fall under. So acute normally happens within like 60 minutes of exposure and lasts like a couple of days. Chronic ultimately is a little bit more severe and can reoccur every few months to weeks, every few days, just depending on what your trigger is. And so I just provided this picture just so you can get a visual of what angioedema actually looks like. So the picture of the man, the diagram, you can tell that this one side of his face has very normal features, but the other side, you can tell his eyes pretty swollen shut, his face is really swollen and puffy, and then his lips as well. And he also does have like swollen hands and arms. So like I said, it can affect the extremities as well. And so like being able to recognize those symptoms is very important. And then these 2 pictures over here just show where this angioedema has affected the tongue in this patient, which can be very life-threatening because at that point it may be affecting the airway. So at that point, it's very important to get medical attention. And then this one right here, you can see that it's starting to affect the lips as well. So we're going to take a little bit of a deeper dive into those different classifications and talk about them a little bit more. So allergic angioedema, like I mentioned, is histamine mediated, which makes sense because it's due to an allergen. So it is angioedema with urticaria. So they're going to have the swelling of their face, but they're also going to have hives. They may have some itching and things of that nature. Normally, the onset is like 30 to 60 minutes after they've been exposed to whatever their allergen may be, but it can be delayed up to 2 to 6 hours after the exposure. So that's important to know that it might not happen immediately. Symptoms reoccur with the repeated exposure to the allergen, which makes sense. If you constantly expose yourself to an allergen, you're probably going to have the same reaction. And most of the common allergens, like I mentioned earlier, are the common causes. So foods, insects, and drugs. For pharmacists, this is the one that we're interested in, is the ACE inhibitor induced. So it is bradykinin mediated in nature. The prevalence is about 0.1 to 2.5%. So it's not rare, but it's not super, super common either. So this is angioedema without urticaria or pruritus, and that is because it's bradykinin in nature. And something I found really interesting was like the onset of symptoms can occur a few hours after starting an ACE inhibitor like lisinopril to even years after starting it. So there's no like safe window. You're out of the window of angioedema when taking an ACE inhibitor. There are a couple patient populations that are at a higher risk, and that is our African Americans and immunocompromised individuals. And the African Americans, like I said, is believed to be due to a genetic polymorphism, and immunocompromised would make sense because that C1 inhibitor is a part of our immune system. So there may be something with that as well. So it is important to know that even if you discontinue the ACE inhibitor, which is what is preferred after an ACE-induced angioedema, that you stop the medication and you don't retry it, you still may have another episode of angioedema within the months to years after. So just kind of knowing that in the back of your head that this could still happen. For some reason, if patients do not discontinue the ACE inhibitor because they have to absolutely have it, the next attack, they say most of the time is within 10 months of the first attack. I'm not sure on why that timeline is, but that is what the stuff that I found said. So just knowing that it's still possible to have another attack even after you stopped the medication. And so hereditary angioedema, which I found very interesting. I did not know it existed until a couple months ago. Again, this is bradykinin mediated in nature. The prevalence is 0.01% to 0.02%. So it's really rare. It's like 1 in 50,000 people. It does present as angioedema with abdominal pain, also abdominal distension. So the belly may be very kind of hard and distended, and an erythematous or red non-itchy rash. So the body just may have this redness appearance all over it. It is autosomal dominant in nature, so it is genetics. So only one parent must have the gene to pass it on to their kid. It does normally present the first time in childhood. It can get worse during their adolescence age, and then they have a peak incidence in their 30s, as I mentioned earlier. They believe that all of this is due to mutations on a different chromosome in our body that ultimately gives us a non-functional C1 inhibitor molecule. So that is where all of that comes from. It is a form of chronic angioedema because it can reoccur very frequently depending on what the cause is. In most patients with chronic angioedema, it is due to like body stress, so like just stress in life, different surgeries, traumas, infections, and things of that nature. So there are 3 major subtypes of hereditary angioedema. So type 1 is about 85% of the population that has hereditary angioedema. And again, like I mentioned, that is the lack of that C1 inhibitor molecule, so they just don't have it. Type 2 is about 15% of patients. This is a dysfunctional one, so it may work sometimes, it may not work all of the time. And then type 3 is actually rare. Couldn't find a percentage on that for you, but it's normally associated with women and women that take estrogen. So in oral contraceptives, or if you have to take estrogens after menopause, during menopause, and things of that nature, because they believe that the estrogen works on that bradykinin pathway that I talked about earlier and can lead to an increase in bradykinin. There was some statistics that I quickly looked at that said like patients that have hereditary angioedema, the average age that people ultimately pass away from an angioedema attack is like 41 years old. So it can be like, it can shorten your life ultimately. with that is being said, we're going to go into the acquired C1 inhibitor deficiency. So kind of the same pathway, but you got this as your life went on. So again, it's bradykinin mediated. It does occur more commonly in those that are older than 40. So that is really where we differentiate from hereditary angioedema, because as I mentioned, that normally presents itself in childhood. So if a patient is like 45 years old and they've come to the doctor, they said, I've never had this before, and they run all these tests, then it's probably acquired because they've never had it up until their 45th birthday. So that's really what helps us differentiate it between hereditary angioedema. Again, it's going to present identical with angioedema with the erythematous non-puritic rash. There still may be some abdominal pain and distension because it is bradykinin mediated. About 15% of cases are due to a lymphoproliferative or an autoimmune condition. Some of the most common being like a lymphoma diagnosis and like a lupus diagnosis. And there are two different subtypes. So the first subtype is basically that disease state. So like lupus or lymphoma basically takes all of the C1 inhibitor out of the body. That's just the way that disease works. And then type 2 is anti-C1 inhibitor autoantibodies. So ultimately that takes, like, the body is taking it all away. And so again, this one is acquired over time. And then last, we have idiopathic angioedema. So it's unknown. We don't know what causes it. So it can be bradykinin or histamine mediated in nature. It's 3+ episodes within 1 year within an indeterminate cause. So we have no idea what's causing this. So it is chronic in nature because it lasts greater than 3 months. And that's the diagnosis, like the definition for chronic. It can be associated with pruritus and urticaria. And to really distinguish if it's histamine or bradykinin mediated, you just kind of have to treat it and try to figure out what it responds to. And we'll talk about the treatment in a second. So if it responds to antihistamine therapy, then it's likely histamine in nature. If it doesn't, then it's likely bradykinin in nature. And this one requires a lot of different testing to try to figure out what the cause may be. So now someone's experiencing an angioedema. What do we do next? So for treatment, the number one treatment is airway assessment and protection. We need to, since it can affect the mouth and the throat, we need to ensure that our patients can breathe. And if they cannot, we give them a way to breathe. Some patients may have to have a endotracheal tube placed to help them breathe and things of that nature, but we need to ensure that our patients can breathe. So if it's histamine mediated, excuse me, we can use antihistamines. And so different antihistamines are like loratadine or Claritin, cetirizine or Zyrtec, and then also famotidine or Pepcid. So our allergy ones like the Claritin and Zyrtec, they hit histamine 1, and then famotidine hits histamine 2. So ultimately we are blocking all histamine that the body is making. And that's what we want because it is that histamine's the cause of the angioedema. Corticosteroids like prednisone, dexamethasone, methylprednisolone, and different things like that can also be used to help reduce some of that inflammation. And then epinephrine is used oftentimes when there is like airway constriction and they need to help get that airway back open. Bradykinin, on the other hand, that bradykinin-mediated angioedema does not respond to antihistamines, corticosteroids, or epinephrine. So if you've tried all those and nothing is resolving, then it is bradykinin-mediated. And so we have a couple different medications. So we have Kalbitor and then icatibant. Those medications work basically by preventing the body from making more bradykinin. So they work in that pathway that I talked about at the beginning, and they stop the body from making bradykinin, because if we're making more bradykinin, then we're further exacerbating the angioedema. Fresh frozen plasma actually can help break down already formed bradykinin. So by using one of the drug and fresh frozen plasma, so using Kalbitor and FFP together, you are stopping the production of bradykinin and you're breaking it down. So that's helping resolve the angioedema attack. For prevention, so we can ultimately try to prevent angioedema attacks, especially in our patients that have like idiopathic, and so they don't really know, or hereditary angioedema or acquired. So if it's histamine mediated, ultimately everybody's going to tell you to avoid the causative agent. If it's an allergen, try to avoid it. Carry an EpiPen. That's also very helpful, especially if you know angioedema can affect your airway. Having an EpiPen is a fantastic idea. Bradykinin does have some specific medications. So we have lanadelumab and berotralstat, which are two medications that ultimately help block the formation of bradykinin. So they work in that pathway that I mentioned earlier by stopping the body from making bradykinin. And ultimately, the biggest way to help prevent and get early treatment for angioedema is to know the signs of an angioedema attack. So remembering these from this presentation, or also if you've had this before, remembering what happened to you before. So if you start to feel those symptoms come on again, you're able to seek medical advice. And so I just wanted to briefly talk about life after an angioedema attack, because that is something that is very important. So you may have to have additional testing and doctor's visits, and a lot of this stems from the cause of angioedema. If it was due to an allergen, you may have to receive allergy testing to help determine if you're allergic to anything else. And if it's genetic in nature, so acquired C1 inhibitor deficiency or the hereditary angioedema, you may have to have genetic testing done to kind of determine that as well. There's obviously going to be increased anxiety and fear just by knowing that that has happened to you and not knowing if it's going to happen again, especially you could get it even after stopping your ACE inhibitor, or if it's hereditary or acquired C1 inhibitor, knowing that it's probably going to happen again depending on your trigger. There can be decreased medication compliance, and a lot of this stems from our drug-induced angioedema. So an example would be our ACE inhibitors are dosed once a day. But once you have an angioedema attack on an ACE inhibitor, you can't take that anymore. So you may go to a different blood pressure medicine that may require you take it twice a day, or 3 times a day, or even 4 times a day, depending on what your doctor wants you to take. And so that could lead to decreased medication compliance by not taking all of the doses just because you're so used to taking one a day, and taking a lot of pills can be burdensome. And there ultimately can be a change in your normal way of life. Depending upon what the cause was, you may have to alter your diet completely if it was due to a food, or if it is hereditary in nature, then you may have to figure out ways that you can adequately manage your external causes of stress and infections and things of that nature to help prevent them from occurring constantly. But that is all I have for angioedema. These are my references, and what questions can I answer for you?
Well done. So who might have questions for her on that?
Very well done. Thank you, Caitlin. I don't have any questions. I just was interested because one of my clients, they're part of the family who supports them. The wife is dealing with this, and it's the C1, the onset as an adult. And the interesting thing is, though, her sister has it too.
Okay.
And so, it's just good information for me to know, because that leaves her husband trying to take care of my client, his mother, and at times wife. And so thank you so much.
Yes, of course. I had seen it on social media a couple months ago, and then having the opportunity to do this, I really wanted to. So thank you for bringing the topic to Dr. Baldwin's attention.
Well, excellent. So are there any other questions?